Okay, guys, we'll start the workshop for antimicrobial stewardship with core elements of antimicrobial stewardship in nursing homes. You know, I know that many of you guys have gone through the antimicrobial stewardship courses before and have seen what needs to be done and what the core elements are. But I think this time around, we decided something different. So yes, we are going to talk about the core elements and going to talk about some of the interventions and things like that. But we will also want to make it a little bit more interactive, thought generating, maybe learning from each other. So these binders that you have with you, and it has some exercise workshops, work activities and things like that. So we'll try to find time so we can discuss some of these things. Some of you already have some experience doing stewardship, so and maybe some of you are new, so we can probably learn from each other too, and not all learning need to come from me or the speakers. So I think that's the goal here. So let's start. Okay, it's just a little stuck, I think.
It wanted to.
Okay, let's see. Yeah, good. Okay, so I think I've spoke about this disclosure that I have a grant from Merck, but that's not necessarily relevant to this particular presentation. These are the objectives for today. Let's talk about the scope of antibiotic overuse, what we see in the US and then in Nebraska, but I think that's the thing that Jenna has, in many of her presentations, she points out that, can you imagine this scenario where you are telling a patient or telling a resident, I don't think you have hypertension, but maybe just take the medication anyhow, because in case you do, so why do we do that for antibiotic? There's no reason, as the side effects can happen from the blood pressure medication, it can happen from antibiotic too, and that's what we're going to talk about a little bit also. When we look at, and this is what we looked at, it was a study that we were doing with some of you here in the audience some time ago into 2017, around 2017, 2018. And we looked at the antibiotic use for like 30 plus nursing homes in Nebraska. And we looked at their antibiotic starts, we looked at their antibiotic days of therapy per 1,000 resident days, and you can see that it was a wide variety of antibiotic starts depending on which facility you are in. Some of these facilities mostly were, short stay. Some of these facilities were mostly long stay, not much short stay patients. But no matter what color you are in, there is a wide variety of how many antibiotics are being used in the building. So there is definitely opportunities for improvement here in Nebraska, correct? We looked at individual courses of antibiotic in the nursing homes. We saw that 41% of antibiotic courses in Nebraska nursing homes around the time of 2017 were inappropriate for whatever reason. So it might be that the criteria was not met for antibiotic and they were started. It might be the long duration. It might be just the wrong choice of antibiotic. And then if we looked at where the antibiotic being prescribed, there were there were about 56%, half of the antibiotic that were being prescribed in the emergency department was not coming down to be the appropriate antibiotic therapy. And same thing with the half of that in the nursing home getting started was not coming out as appropriate also. And about half of, or a little more than half in outpatient setting that was getting started, like in the primary care doctor's office or whatsoever, they were not appropriate either. So these are actual Nebraska long-term care facilities where we looked at every single antibiotic being used by the pharmacist of that facility, and that's the data that we are talking about here. So in terms of the adverse effect, you can see 3% of the courses they, were determined to have by the pharmacist of the facility are having some adverse effect, and that included either C. difficile infection and allergic reaction. And I can tell you that I don't even know whether every single adverse event was being recorded. But with that being recorded, we were still finding all of that, correct? So how does this antibiotic resistance happen? So it starts with infection. Definitely you have infection, you have a pathogenic bacteria that is now mixed with your good bacteria. Then the patient starts receiving antibiotics. Then both pathogenic and good bacteria start to decrease in number, correct? Because the antibiotic is killing both. Then if we continue the antibiotics, the good bacteria continue to decrease in numbers, and the pathogenic bacteria now start to mutate. Because they're kind of getting pressure of antibiotic and they are evolving. So they start to mutate and become resistant to survive while good bacteria continue to die. Then, as the antibiotic continues longer, the bacteria start to share their genetic material with other bacteria. And we have seen that, we actually have examples of that in Nebraska where we have documented that the genes from one bacteria hops on to another bacteria. And that's the transmission is happening among patients, but the transmission is happening among the bacteria itself. In their own community, they are transmitting highly resistant genes to each other, while we are having transmission in the facility from person to person. So that will start to happen if you keep going on that route. And then, when antibiotic durations are prolonged, eventually, then you will start to see the transmission in the building. That's how it works if antibiotic pressure continues. So why are we so much talking about resistance? Is because of the fact that we don't have that many treatment options. If we don't have treatment options, eventually, we will have less options to treat a patient. And if somebody doesn't respond to one antibiotic or whatever happened, if they develop resistance to that antibiotic, then we may not even have an antibiotic to treat that patient. Then there is a longer recovery time. So when you have those resistant bacteria, you're delaying the start of effective treatment because you started on an antibiotic that didn't work. Then they are staying in the hospital longer, more complication, more severe illness. And then ultimately it can spread. These bacteria have been shown to spread within the long-term care facility, within the acute care facilities, and some even in communities can happen, correct? So that's why all of that matter. That's why we are talking about all of that. And how common are antibiotic-related adverse events? So antimicrobials are actually the second most frequent cause of medication-related adverse drug events leading to the emergency department visits. And then in hospitalized patients who receive antibiotic for more than 24 hours, 1 in 5, like 20%, will experience an adverse drug event. 20% will see an adverse drug event. Now we saw 3% of our courses, but as I was saying, that we're not doing a good job in actually recording all the adverse event either. When people have looked into it, more thoroughly, in larger sample size and things like that, what they have seen is about there's a 4% increase in odds of getting an adverse event every day. 4% increase in the odds as long as you're continuing that antibiotic. If you're looking at 5 versus 3 days of antibiotic, that increased days that you are giving, from 3 to 5, there is a 9% increase odds of having an adverse event. When you're going from 3 days to 7 days, there is a 19% increase odds of having an adverse event. So these are the things that we need to consider when we are prescribing antibiotics. And then there is secondary infections that happens because we gave somebody an antibiotic for an infection. So these secondary infections are like C. difficile infection, because good bacteria dies, C. difficile take over, or vaginitis, or oral thrush. All of these happens because your normal flora has been disrupted, and now you are starting to see that. So that another thing that we always have to keep in mind, that these are adverse event too, in a sense. And we have seen in studies that people sometimes prescribe antibiotic, or prescribers sometimes prescribe antibiotics, not because it is needed. Dr. Morgan was kind of talking about some of that. They are prescribing antibiotic for other reasons, for fear, for risk mitigation, for or just kind of, hey, if I prescribe an antibiotic, I get off faster. If I have to talk to somebody for 10 minutes, just give them the antibiotic and move on. And that happens. Sometimes it's outside influence. It's not our long-term care providers who are providing it. Somebody else is prescribing that. There's either emergency department or an outpatient facility. There's communication gaps that can happen among the staff that leads to antibiotic prescribing. How you present an information to a provider, how as a nursing staff you present information to a provider can lead to that. I'm a geriatrician too. I have worked in a nursing home as as a geriatrician or a geriatric training fellow, and I used to get called, in the middle of the night. That was before I was an infectious disease. So don't. What I'm about to say, don't judge me on that. But I used to get calls too for the in the middle of the night for somebody asking me, can I, order this urine culture or things like that. The problem in those type of situations. Okay, I'm not going to tell you what I did. But the problem in that situation is that this. If you get a call as a provider, you get a call and it's 12 midnight, and you were sleeping and just have a 1 hour sleep, and they woke up, and the person on the other side is saying, hey, this person does not look right or feel right. The last time this happened, it was a UTI. Can I obtain a urine culture at this point? Okay, what's the right response? The right response is, what symptom does this patient have? Does this patient have fever? I can check the temperature and get back to you. Okay, fine. Okay. And is she complaining of any pain right now with peeing? No. Okay, fine. Can you find out all this? Okay. Then you get a call half an hour later, correct? Then you wake up again, and then you say, okay, great. Now tell me, what they have and what they don't have. Did you actually looked at the bladder? Was it painful? Oh, hold on, let me just go and check. So that's not going to work, correct? That is not going to work. That's why the answer in those situations is, yes, please go ahead. Do what you need to do. Okay. That's why having a communication pathway is important, so that when you get that call, right from the beginning. The resident and family pressure is another reason that we see the problems, correct? But that's because of us too. We have given them wrong information for so long, in our practice, that now they kind of say, okay, what were you telling me last 20 years already changed like in one day? And that's the problem that we end up into sometimes. There was this study that was done, some time ago in Canada, where they looked at, I think this was like a statewide or something like that. Every single provider of nursing home, they looked at that. Okay. Every dot is one prescriber. Every dot is one prescriber. Okay. And what we are seeing here is that there are some prescribers on the top there. There are some prescribers. So these are how many prescriptions they prescribe, correct? And if you go there, this prescriber have over 100 prescription, and almost all the time, almost 90+% of the time, provided a duration of more than 7 days. Every single prescription, or 7 days or so. And here, we have a provider like have 220 prescriptions or whatsoever. Almost always, 90+ of the time, have less than 7 days duration. So what's the difference between this provider, patient population and this provider patient population? Absolutely nothing. There's no difference in the patient population that this prescriber is prescribing for and that prescriber is prescribing for. It is based on what they do, what their common prescription writing pattern is. If they always say, do the antibiotics for 3 days, then they will always say, do the antibiotic for 3 days. If they always say, do the antibiotic for 10 days, they will always, it's not going on what's going on with the patient is, or what's going on with the resident is what they usually do. It's out of the habit, so that's basically, the point here. So what nursing homes need to do is to create a culture of safety around antibiotic prescribing and have that discussion, definitely talk to the team, when making the decision, have the right information, develop tools and strategies to help guide the process, the right communication, have the communication techniques so that doesn't happen. That happened to me in the middle of the night. Set up, safe design principles, so standardization of the process, and then, checklist and things like that, that we can use to promote appropriate antibiotic prescribing. We want to sustain the stewardship in long-term care facilities, a successful program in long-term care facilities. We need leadership support. Without the leadership support, is not going to happen. We've tried that a long time. If there's good leadership support, it happens. If there's no good support, it does not happen. You probably will need some kind of external stewardship expert support. That's why we built the Stewardship ASAP program, so that at least if you need help, you have somebody outside to go to and ask questions and things like that. There are internal collaboration that will be needed, internal discussion that will be needed, internal expertise that will be needed also. So you need to have all those internal processes, figured out, and then consistent education and training and all those things. So that's what we're going to talk about as we go forward. So that is what and actually that's exactly what the CMS says. But the CMS says that every facility have to have an antimicrobial stewardship program, correct? And what they say is that those programs should be modeled based on the CDC core elements. But also have something about medical director and the pharmacist. And so it's not only infection preventionist that is going to be doing that. This is actually in the surveyor guidance that Dan Taylor have said that they are going to be following right now, correct? This is that guidance, that advanced copy stamp on it, and is saying, that's what we have right now. That's what we're going to follow. And that says, that this development should include leadership support and accountability via the participation of the medical director, consulting pharmacist, nursing and administrative leadership, and the individual with the design responsibility for the infection control program. So infection preventionists, but not alone. Medical director, consultant pharmacist, director of nursing, administrative leadership. That brings up to, okay, and then they say that it has to be modeled after the CDC core element. So what is the CDC core element? The leadership commitment, the accountability, the drug expertise, the action tracking, reporting, and education. Okay, so leadership commitment, what do we need for that? If you can, get a written statement of support for a stewardship program, make sure that everybody is aware of it, what it says. some facilities actually email it out to all the providers that are prescribing in the building, so they know that this facility have a program. And if I may get called, that's not because this nursing staff is going to be just trying to question me. Is because that there is a program that they are actually following, and they are calling for that. So setting up that standard should be by the leadership, that they should do that, outline the duties of this stewardship team members, communicate the expectations, create a culture that we talk about, promote appropriate antibiotic use. And for you who are on the front line, how do you engage your leadership? You should be, you should be very clear when you go to the leadership what support you want from them. Do you want them to support you to get the message out to the frontline providers? Do you want to support them to have the medical director, attend the meeting? What do you want from the leadership that you want going to ask for? Be specific about that. Be prepared about that. Show them the data. Show them the CMS regulation. Show them where it says that medical director, consultant pharmacist, and everybody needs to be involved, and then and have anticipates what obstacles you are going to have, figure out the solution with the team, and then give it some time, implement one by one, keep it simple, and then see whether it gets better or not. Then you come back, and then you do the whole PDSA cycle that we're going to talk about. So that's just a sample leadership statement of support that some facilities have adopted and in their own thing, and then emailed out to all their providers and things like that. So that can be, it's on the website. I'm not going to go into those details, and probably maybe in the binders too. So so we're just going to quickly go through that so we can talk about some real life scenarios. Accountability is the second core element. How do you meet that? You define the roles of everybody in the leadership program, correct? You provide them dedicated time. Not that you were already doing the full-time job of something else like quality or whatever, and now you are also the stewardship lead. Okay, what do I stop doing? No, nothing. Just do this more. How? Figure it out. So that's not going to work. Okay, make the team accountable, and one of the way make them accountable is to give them the time so that they can be accountable for that. Correct. Develop partnership with consultant laboratories, your pharmacists, the health department, ASAP. All of that is going to be needed, but it's all part of the accountability. Everybody should know what their role is, and they have time to do the work. And then, one way of accountability is to define the role and give them a task in a committee to come together and do the work, correct? What the PALTMED, previously AMDA policy statement that was published tells us that the committee should meet at least quarterly, and they review the policy and program annually as needed. And these are the members that you will want in the committee. There are always ad hoc members that you can have in the committee. As I said, everybody has a role. Medical director sets the standards for antibiotic prescribing, help decide priorities. The director of nursing sets the practice standard. How are you going to communicate? How are you going to monitor? How are you going to assess? That's going to be the director of nursing job. The consultant pharmacist will support antibiotic stewardship oversight through QI activities, reviewing the medications, maybe even sending feedback letters to the provider for when they identify something that is not right, or when they see the adverse event and things like that. They can also help in many other different ways I can talk about later. And then infection prevention will perform the surveillance data analysis to inform strategies to improve antibiotic use. That's the paper that I was talking about that have the policy template. It's a very long policy, but it actually goes very well. So if you find this paper and read this paper, you probably will find it very, very helpful. It will probably increase my number of things written by me, correct? So that also would matter. And then this is a modifiable version of that, like brief version from that basic policy statement to just kind of show you an example of, okay, you don't have to write 5-page policy, but we can kind of do something where you define the role, set the goals, and what the responsibilities of the committee will be. Okay, so that's accountability. We set the accountability. Now we're coming into the drug expertise part. In the drug expertise, we need to establish access to individuals with antibiotic expertise to implement antibiotic stewardship activities. So where do you find these drug experts? So first of all, you can talk to your consultant pharmacist who may have received a specialized infectious disease or stewardship training. Now, in Nebraska, I think we have trained over 25 or so consultant pharmacists already through our different programs. The program that we did in 2017 and the program that we just finished last year, where we kind of have 22 pharmacists graduated from that program. So, maybe they are one of them. And if they are not, there are other programs that are out there where they get training. So have them get that training and then talk to them to really help you. Sometimes it might need a contract or whatsoever, but that's fine. They can help if you contract with them, and if they have the specialized training, they can help. We will also plan to have an online training option pretty soon that will be available for consultant pharmacists, where they can actually take a course and get some training. So we're working on that. And then if you don't have that, then you can look for people in your network, like the hospital stewardship program or things like that, or any infectious disease physician in your community. So try to establish somebody who can help you when the questions arise, when the policy has to be made, that you can send it to somebody and can say, okay, yeah, that makes sense, or does not make sense. Now, the consultant pharmacist, again, in the same guidance that our licensure use, it says this about antibiotic stewardship program in relation to pharmacy services. It's actually very clearly written. The assessment, monitoring, and communication of antibiotic use shall occur by a licensed pharmacist in accordance with drug regimen review. A pharmacist must perform a medication regimen review at least monthly, including review of the medical record and identify any irregularities, including unnecessary drug. Now, what I will say is that if they are trained in doing that process and know how to do that, they probably will do even a better job. Every pharmacist should be able to do this on a basic level, but I think the ones that are trained in the pharmacist level, they actually know how to use this information to drive the next step from it, and that's what we are asking facilities to work with. CDC have their own opinion about how or guidance about how consultant pharmacists can help. They can review the indication for every order. They can make sure that people are using the shortest effective duration, improving the fluoroquinolone prescribing practices to decrease the use of fluoroquinolone, avoid treatment of asymptomatic bacteria. They can help with that because they're doing the review of the chart and things like that. They can provide feedback, limit the use of prolonged antibiotic prophylaxis for UTI is another thing that can be done, because we shouldn't be using long-term antibiotic prophylaxis for UTI in most of the situation. So if you see something there, they can actually do some interventions to decrease it. So that was the CDC that have the 5 things. I just wrote something that have 50 things that they can do. But you want to read that, please go ahead and read that also. But there are definitely many different ways that can, and whatever is written in there is not hypothetical. We have some audience member who actually have done that and have shown that it can be done. So this is not a hypothetical things that is written in there. So summarizing the first 3 core elements, forming an antibiotic stewardship committee, defining the responsibilities of the goal of the committee, providing the protected time to achieve the goal, establishing team meetings, developing stewardship policy, informing prescribers and nursing staff about their roles, and then building relationship with regional antibiotic stewardship experts. That will give you the leadership commitment, the accountability, and the drug expertise done. And then you will come to the action. Okay, what is that committee going to do? It's going to drive some action. And what are the kind of actions? So first of all, having a policy for optimal antibiotic use. We shared a template before. We talked about a paper before. Infection and specific syndrome is specific interventions. So we are going to have a talk right after this talk where you will go into that infection is syndrome specific intervention part, and then the pharmacy intervention. You will have a tracking and reporting part that will kind of go into the pharmacy intervention part, plus also what we talk about the consultant pharmacist can be a pharmacy intervention things too. And then these broad interventions like QI kind of interventions that you can do that are like algorithms like S-bars or communication tool, how, scripted communication that the staff can use to talk to the people about or prescribers about antibiotic timeout, guidelines, some kind of a feedback system that either a pharmacist can do or IP can do or medical director can do. Those are the actions that you can develop as a QI project for your facility. And there are a lot of ideas and things like that in the AHRQ program toolkits. I'm not going to go into detail of that, but if you go and have time, click around the AHRQ stewardship program toolkits and see what kind of different good options they have available for stewardship implementation. So how do you choose an antibiotic stewardship intervention? You review your data, you see your data to see what are the improvement opportunities there. You obtain the input from both the program leaders and the frontline staff. Then you establish, okay, these are the 5 things we need to get better. What priority we have? Then you look for something that is low effort but high impact. So you can do it in not so much changing so many things, but it can give you a better impact eventually. And then you start with that. Keep the thing simple. Start with that. When it gets better, you assess, and then we'll go into tracking and reporting and things like that. And then you go from there. Then we will have a core elements, tracking, reporting, education. I'm not going to go in detail because we have sessions for that later on. I wanted to talk about this a little. If this is a report from a facility, a made-up report, but you can see in there's several different things you can see in there that can be picked up on. Correct? The UTI it looks like to be the driver of the antibiotic use at this facility. The skin and soft tissue, we don't even know whether they are meeting the criteria, they're not meeting the criteria. That might be something that they can actually look at to know whether these are not. Plus, 59% of the UTI did not meet any criteria. That's a problem, correct? You can see the problem right there. So you're reviewing the data and you kind of, okay, problem number 1, UTI, skin and soft tissue infection is a high, but I don't know why. Problem number 2, no indication. 8, why do we not have an indication? Problem number 3, correct? Then, ciprofloxacin is the most used antibiotic. That shouldn't be the fluoroquinolone. Should be the first antibiotic or the most used antibiotics in our facility. Problem number 5. So now you're kind of you're identifying your problem, and then you say, okay, what do I do? What are the top inputs? I cannot fix everything in the first day, but what can I fix that can be easily fixed but can give us the high impact? And that's how you decide. So based on what are you trying to achieve, then you develop your implementation. If you are going to, okay, we want to make sure that antibiotic we prescribe are meeting the clinical criteria, then you need an S-bar tool implementation. If the diagnostic tests are being sent unnecessarily, then you need some kind of a S-bar or algorithm making so that we can send the urine culture only when it's needed. If there is an inappropriate length of therapy, you need a guidance for UTI, we will use 3 days for female patients or whatever. That is how you're going to start to see what is the target, what is the intervention, what is the target. So the intervention you choose will be based on your problem of the target that you're looking at. So it's basically you review the data, you identify opportunities, you develop an action plan, you then implement that action that you decided on, educate the provider, then track your antibiotic use, track your process measure, then you reanalyze your data. See, did improvement happen or not happen? And did not happen, what went wrong? Then you develop plan again to address the barriers you identified, and then you go back all over again, correct? That is what it is. that's it for now. And then we're going to go into discussion mode now. So are we going to stop this and then go into discussion mode? I thought that's what the plan. No? Yes? Okay.
Okay. So to start, does anybody have questions on that and maybe you would want to come to the microphone and don't be shy. You've got one of the best people in the country right here. If you want to come over, I'm not lying. I'm not lying. This guy gets a lot of invitations, but if you have a question or you're seeing something in your practice, like by all means, you're not the only one with that question. So don't be